I'm Michelle Mabry, a clinical supervisor with Nutritious Lifestyles. I have the pleasure of introducing to you today Janet McKee, the president and owner of Nutritious Lifestyles, which is a group of 180 dietitians, chefs, and CDMs that provide nutrition and food service consultations nationally. Janet specializes in adult and geriatric nutrition, nutrition for renal disease and pressure ulcers, and speaks nationally on nutrition for the healthcare and food industries. She is a board-certified specialist in geriatric nutrition, as well as a diplomat with the American Professional Wound Care Association. Janet has important updates to share with us today to help aid in resident care during these challenging times. So without further ado, I'm going to turn the stage over to Janet now.
Thank you, Michelle, for that warm welcome. So unfortunately, as we know, COVID is here, and we really do not expect a vaccine within the next 30 days. Hopefully we'll get one later this fall or the first of the year. But then we have to think about how long it will take to disseminate that. So as we go along, we do expect COVID to be continued in our nursing home and behavioral clients. So the purpose of today's consultation has to really look into what is going to be the plan of care to help these people avoid COVID, and how can we, once they're positive, provide nutritional care for them to survive, and not only that, post-COVID to thrive. So our objectives are to talk about different approaches to help our residents avoid getting malnutrition or losing weight, which sets them up for a possible COVID infection. We will be able to identify 5 effects of COVID-19 that may affect nutritional status. For example, many people have massive diarrhea and GI distress. Other people are affected by respiratory distress, some people not at all for either. We will be able to discuss how COVID and the febrile conditions that affect the diagnosis of COVID bring increased nutrient needs to the human body, and how we might approach that through care planning. So we know that COVID is here. We all know about COVID, but to summarize that, we know that it's highly contagious. We know it's airborne. We do not believe it's foodborne. We know that many people do get a fever. Some people do not. They also have a respiratory tract syndrome most of the time, about 75% of the time, that are COVID positive with symptoms. And multi-organ failure is huge for many people with GI distress. Also, it affects our ability to smell. So COVID-19 is much more likely to affect an individual that has diabetes, coronary artery disease, respiratory problems, cancer. Those all increase the risk of diminished immunity, and it also increases the risk of severe symptoms and fatality. Most of our residents have more or one of the above symptoms or diagnostics, and our residents truly are at risk for this. Here are the facts. We have close to 6 million confirmed cases in the United States, 180,000 plus deaths. 50%, depending on who you read. One week, the Wall Street Journal had 50% of the deaths are in the elderly in nursing homes. The next week, it was 40%, so it varies. But the large amount of fatalities are in the compromised immunity client and the elderly. 0.5 to 1% of COVID cases that are diagnosed end up to be fatalities. So many of us have been in long-term care and behavioral care for many years, and we all know that our goal is to truly keep our residents safe. The goal is to talk about some ways to do this and avoid the infection, and once they get it, how to treat them and do our part with hydration and food administration to keep them healthy, well-nourished, and beat COVID. So COVID, for one, I can tell you, is unpredictable. There's no rhyme. There is no reason. It has short-term effects and long-term effects depending on the person. So I'm going to give you a personal example. My son Campbell, that's 17, plays competitive basketball on AAU. One of his teammates tested positive, so we recruited. It took our entire family to get tested. All of us were negative for the virus and antibodies except for Campbell. He tested positive, had no signs and symptoms. He was placed on, and his antibodies were negative too, as well as ours. So we retested in 10 days. We were all negative again for the virus. And these were the type that were sent to a lab, so the accuracy was high, reportedly. And also, our immunities were negative, again, with the exception of Campbell. His immunities were negative, however, he did test positive once again for the virus. So, completely asymptomatic, no sniffles, no fever, nothing. So, of course, the more we know, the more questions we have. There are people that had the virus in May of this year that still, the virus is having negative digestive problems with them. Some people have had organ issues. So after the fact, so we really just don't know for sure the long-term and short-term effects of this virus. So safety is key to keep our residents safe. So prevention of COVID-19 in nursing and behavioral facilities. An ounce of prevention is worth a pound of cure. There are so many different ways that we can protect ourselves and our residents. And we need to be using protective wear for ourselves and also for our residents. And again, we worry a lot about our clients, our residents, and our vendor partners and staff. Masks are needed. Gloves are needed. Protective eyewear is now required in many states. Again, the mucosa cells that are on the outside of the inner eyelid, the lips, so to speak, they are susceptible that if someone spews in the air, that a globule of the virus can enter through that system. Social distancing is a must. Following your policies and taking temperatures in the lobby and following the standards established by your facilities. The number one way to keep our residents safe is to practice infection control, the social distancing that we've discussed, the hand washing, the pump of alcohol / the sanitizing agents that have a minimum of 60% alcohol to keep ourselves safe. But it's also equally important to keep our residents well nourished and also hydrated. We know that people that are malnourished get infections. We know that people dehydrated, they don't have the ability to flush viruses out of their nasal cavity. So they tend to stay in there. The dry mucus is more friendly to bacterial and viral loads. So it's important that we remember that they need to stay well nourished and healthy. And it's challenging because many of us know our residents have not seen a family member in literally months. And they're isolated, they're lonely. And being in an unsocial environment has had a negative effect on their appetites and in many cases promoted weight loss. So malnutrition and dehydration reduces immunity. It's a fact. If you lose even 3% of the weight of an elderly individual in an unplanned, rapid fashion, it increases the risk of infections, both bacterial and viral. So COVID has a lot of negative effects on nutritional quality of life, nutritional status and quality of life. Well, we know that it decreases intakes. If you have a upper respiratory infection, it's going to affect your intake. It causes undernutrition, acute. It also can promote depression, immobility from weakness, dehydration from lack of feeling like drinking, declining strength, reduction in lean body mass, severe inflammation. This is an inflammatory disease process, involuntary weight loss, fragility. And most importantly, we don't think about this, but for months and months and months, residents, young people and old people, many people that have COVID have taste disorders for long periods of time. So your olfactory buds are little live tissues. They sort of look like a light bulb. And when they are damaged, it can take months for them to restore. During this time, the food for these residents may truly taste like straw. Edema, isolation, dysphagia. You lose 5% of your weight as an elderly person, your chance of dysphagia goes up 80%. Increased difficulty managing blood sugar for chronic diabetes, etc. GI distress, acute and long-term, both nausea and vomiting, increased GERD and diarrhea. These are all consequences or potential consequences of COVID. COVID causes an acute inflammatory state. So when that virus who goes in through your nose for the most part, or your hands through your mouth, we know that it causes instantaneously inflammation. It's an infection. It's in a foreign body. So our body starts immediately trying to fight off the infection. Instead of our body making albumin, our body starts making C-reactive protein and other negative phase reactant proteins. So then that infection state has inflammation, and what has happened, according to our residents and our patients in the literature, is it decreases appetites, therefore increasing the risk of weight loss, therefore increasing nutritional risk and declines. So we know that COVID is an infection. All infections are hypermetabolic, catabolic, and if they have a fever, you can increase, I believe it's 7.8 increase in percentage of calorie needs. For every temperature degree, you are above 98.6, so that is significant. COVID-19 increases your calorie, fluid, and protein needs. Many healthy young people, including teens and youthful adults, are COVID carriers. They are positive, but they're asymptomatic carriers. So when you involve yourself with a person that's a carrier, they may be completely asymptomatic. However, you may be the unfortunate one that picks up this virus. And depending on the person, it can even attack your cardiac muscle. So there's receptor sites in the cardiac muscle that will accept this attachment of the virus. Our elderly people with chronic conditions are at high risk for COVID, and especially increased fatalities. Diabetes, uncontrolled, with elevated blood sugars consistently has a 254% increase in fatality rates. Coronary disease, upper respiratory infections such as pneumonia, cancer, immune compromise such as HIV, obesity, COPD, UTIs, and renal disease such as those requiring hemodialysis, they all are at high risk from death, infection, complications, and increased fatalities. So nutrition is key. Remember, many of you are clients, and remote referrals from the EMR are available, and we are truly a phone call away. So for you that are Nutritious Lifestyles customers, please make sure that you as DONs and you as CDMs have the dietitian consultant's cell phone number and email address. And for after hours calls, please call us at our toll-free number if you need help with a tube feeding, an issue, a menu change, whatever, call us at 877-894-0401. So most facilities do assessments and screens. Our pattern at Nutritious Lifestyles is to do screens using validated screens such as this SNAC, such as the M&A, such as the MUST, are done on all admissions and really should be done on all positive 19 patients, because for COVID, we know that those patients are very, very, very much at risk. Here's an example of the M&A. So the M&A is one validated tool. It has an 86% accuracy and validity rate. That's pretty good. So start nutrition interventions ASAP on high-risk triggered residents, including COVID. So those that are at risk are enteral nutrition, receiving dialysis, triggered because they have a poor appetite, they scored like a very low score on the diagnostic. Don't feel like you have to wait for the dietitian to start your nutrition care plans. Whenever you have a nutritional diagnostic, within 24 to 72 hours of admission to your facility, you really should have started a nutrition interim plan of care for those identified problems. So here's a care plan for weight loss. We provide these to all our clients. And here's a sample of an interim plan of care. Again, interim plans of care should be implemented as soon as possible after admission, between 24 and 72 hours for nutritional problems. This particular problem is the person has COPD, they're at nutritional risk, they have diabetes, they have poor intakes, and have recent significant weight loss. So our goal for this particular patient is to maintain a weight of 150 to 155. So our approaches are consult the dietitian, obtain food preferences, add a fortified food, monitor weights and intakes. So this is just a sample, and again, our survey process requires interim nutrition plans of care as well as other nutrition plans of care to address issues, including, example, a pressure ulcer. So we want to start these interventions that are feasible and simplistic after identifying high-risk status by your dietary management team and your nursing staff. There's no need to wait for the dietitian. Their role is to conduct a comprehensive assessment and add in what the status that may have changed between you and them seeing them, but also to implement additional interventions. So we need to make sure that when we have a COVID positive client or someone that's very sick or a new admission, that we have a system that makes sure our registered dietitian, our nutritionist, diet tech that's registered, completes a comprehensive, timely assessment on all high-risk patients that are on TPN, have pressure ulcers that are hemodialysis, on enteral feedings, which is also called a tube feeding. They're high risk and need to be seen by a dietitian. All COVID residents should have screens and also be monitored for nutrition interventions. So our rule as a team is once that dietitian or diet technician completes that assessment, we need to make sure that it's done timely and those recommendations are in order. If a dietitian recommends fortified foods and they don't get done, that's an ineffective intervention that when the state comes and checks the tray line and there's no fortified food as there's continued weight loss, it can result in an IJ, which we do not want that for you, or a negative outcome for our residents. So we need to think about our assessment and look and see what's going on and look for things the dietitian may have missed that we may have found out about by looking at, for example, depression based on the social services notes. So we know that we need to look at respiratory status. Since the dietitian saw them, they could have had in need for respiratory therapists. They could have gotten a fever. They could be short of breath. They could have developed, because dehydration causes acute kidney failure. Maybe they didn't eat well. They were discharged out from our facility or back 2 days later with acute kidney injury that was related to dehydration. Are they on isolation trays? People on isolation trays tend to eat less. Socialization causes us as humans to eat more. That's why they call from, I believe it's the week before Thanksgiving to January 1st, the holiday 10. So approximately people that are challenged to stay away from party foods, many of them will gain 10 pounds during that period of time. Looking at their weight loss history, poor appetites, dysphagia, again, if someone comes in and is already weak and they get COVID, they lose a couple of pounds, they may not be able to swallow very well or feed themselves because of declining hand strength. Think about their taste. Maybe if they're not eating, maybe they need to have enhanced food taste, such as fortified foods, because their ability to taste has declined. And really, who would really mind if a diabetic had cake? We have insulin. Let them eat and enjoy their food and get those calories in them. The lack of socialization, how does that affect intake? When you have COVID, it weakens you. It causes lean body mass wasting. Did it reduce that said individual's ability to feed themselves? Have they lost strength? Look at your PT and OT notes. If they've lost strength, a lot of times it is related to weight loss. Read those notes, it'll tell you a lot. And of course, COVID is associated with weakness. Here's a sample assessment note by an RD or NDTR. Mr. Van Loon is a 78-year-old man with vascular dementia / Alzheimer's, muscle weakness. He was currently a resident at Gentlebrooke Assisted Living. Mr. Balloon was discharged because they don't take COVID patients there. He's positive for COVID-19. His intake is merely 30% on average. His weight is 150. His height is 5'8". He's had a weight loss of 10% in the last 2 weeks. He at least 2,100 calories and 85 grams of protein and 2,000 cc's of fluid daily. On 30%, it's clear he's not meeting his needs on his regular no added salt diet. Additionally, when the dietitian saw him, she noted that his hand strength, he could not grasp her hand and hold it tightly for 5 seconds, which is a classic sign of muscle weakness and declining muscle mass. So Mr. Van Loon is struggling eating his meals independently, and at the middle of the meal, he's just tuckered out. And at the end of meals, Mr. Van Loon is at the risk for nutritional declines and continued involuntary weight loss due to poor intakes and the acute diagnostic of COVID-19. The resident has complained to said dietitian and dietary manager that the food tastes like straw. So the dietitian recommended for the food service director to either pick up the initial food preferences or come back and revise them, refer to occupational therapy to look at the need for adaptive equipment or restorative dining or assistance at meals, offering 2 high-calorie, high-protein snacks because the intake will be inadequate at the intake, such as whole chocolate milk and vanilla cookies, such as cookies with milk or chocolate milk with a slice of pound cake, fortified soup and potato cycle lunch. So Monday you have fortified soup, Tuesday you have potatoes, Wednesday you have a different fortified soup and stuff, and throughout the week. Weekly weights. So our role is to take those recommendations and implement a plan of care or revise the current plan of care as clinicians in the facility. As dietitians, but also as dietary managers and DONs, we all should be working together on the plan of care. So here's a sample care plan. This would be a nutritional issue that's related to acute COVID. So at risk of due to COVID-19 is positive, he had a positive test, poor intakes, taste declines, and weight loss. So our goal is to maintain 50 to 75% of intakes. We're going to consult the dietitian, monitor intake, weights, add a fortified food, have 2 high-calorie, high-protein snacks, and we're going to obtain and continue to honor the food preferences. That's the solid care plan that absolutely has to be done by the 21st day post-admission. So what we should be doing, even if a COVID person is not losing weight, is COVID positive, we need to be doing weekly weights. We need to use our EMRs to identify those clients that are eating poorly. We need a red flag system to help them because we don't want them to lose weight. We don't to address the poor intakes after the fact of weight loss, but before, to catch it before the weight loss occurs. So visit your residents on your rounds. Visit them. And you can look at a resident many times and tell they're emaciated or losing weight. Their face looks like Jed Clampett's dog on the Beverly Hillbillies, that their faces, their buccal folds are all loose and hanging. Poor intakes are obvious if you're doing a lunch round. Facial wasting, weak hand strength. Again, your strength is in your hands. It's the first to go when malnutrition starts. Skin condition, looking at feeding needs. Collaboration with OT and ST and restorative dining, reviewing ADLs. Refer residents to the RD and DTR as needed. ASAP when somebody is COVID. So you got the assessment we gave you, but what else could we do? Well, as a team, let's chat. That's the purpose of care planning and communication. Can we liberalize the diet more? Does it really matter if someone that has COVID-19 and lost 10 pounds, if they eat a piece of bacon or if they add extra salt to their plate? Can we look at using enhanced flavor foods? For example, if everything tastes like straw, you might want to give an extra high-calorie dessert, which a lot of people will be able to taste the sweets, but nothing else. So look at fortifying foods, always honoring the food preferences. Comfort foods are big and inexpensive right now. Macaroni and cheese goes over very, very well. It's a starch and a protein, easy to chew and very tasty. And again, you'll see more and more people converting to lots of mashed potatoes, softer noodles, spaghetti and meatballs, shepherd's pie, spaghetti pie. You'll want to make sure that there's good communication with the RD or the NDTR through referrals, through the EMR process or telephonically. Visit the residents. Aromatherapy. Many studies have shown, and I've seen it myself, that aromatherapy with meals as well as activity time can definitely help improve one's appetite. These people get exhausted from feeding themselves a whole meal. Perhaps a consideration would be to have 5 to 6 small meals a day. So, for example, have small portions and 2 heavy snacks like chocolate milk and Lorna Doones at 3 o'clock to the tune of 250 calories at that meal, and maybe they could have cereal and milk and banana, another couple hundred calories at night. Sometimes their fluid and their food needs need to be, consistency needs to be changed. If you're too weak to eat, you're probably too weak to cut your own food. Perhaps your food needs to be diced/mechanical salt. And certainly collaborating with the rehab team and your peers. So for the nursing home industry, in my opinion, and also in many other dietitian and physicians' opinion, diet should be a 4-letter word. We want to keep our residents weight on them. We want to make those people happy. They have a huge amount of time they spend in a nursing home without a lot to do sometimes, and so we want to make meals exciting. Socialization is important and as positive as possible. So low cholesterol, low fat, low sodium, diabetic, none of those diets have shown to have any positive outcomes on the elderly. So as we said before, many clients tell me that their food tastes like straw. So overcoming the taste, strawberry. Can we add extra fat? So for once in our life, we're going to focus on adding more fat, not less. Are we adding liberal salt? Because you lose your ability to taste salt if you're an older person that gets COVID. Are we using spices? Are we using sugar to dice up the food or make it spicy? Are we using cost-effective menu alternatives in foods that wake up the taste buds with experiencing flavor enhancers like gravy, margarine, spices, rosemary, basil, lemon pepper, sugar, thyme, and yes, MSG. Unless you have an allergic reaction to MSG, it is a great flavor enhancer. Chili and cinnamon. So enhanced foods are the way to go for COVID-19 and people losing weight. Get a lot of bang for your buck. You get increased protein, increased calories, increased fat intakes. You can use half and half in whole milk versus low-fat milk to boost those calories. You can use protein powders. For example, you can add, to keep your costs down, you can make pudding from a mix and use powdered milk in the product to beef up your protein content. Eggs, meat patties, high-calorie results. Again, the elderly tend to love sweets, and when they have lost their taste during COVID, it has been explained to me that some of these sweet, soft desserts like peanut butter pie, that's a Cool Whip product, cream cheese product, and a peanut butter mixed powdered sugar product, is very soothing to them. That carries flavor. That's why when Kentucky Fried Chicken made their sandwich this past summer, in May, it flew off the shelves. It was fabulous. The biscuits have fat in them, the fried chicken have fat, and frankly, it was a great flavor. Butter and margarine carry flavor, pie crust carry flavor, gravies carry flavor. Again, fat is a flavor carrier, so use it liberally to prevent weight loss with COVID. You can use half and half in recipes in place of milk. So if you look at this, this is potatoes that are made with half and half, mashed potatoes, and a chicken / Creole type soup, and it has, tomato soup, and it has a half and half addition to it versus water. So a cup of milk has 103 calories and 8 or 9 grams of protein. A cup of half and half has 320 calories and 8 grams of protein. So approximately 300% bang for the buck using a half and half. Fortify your recipes, your snack patterns, your foods. Increase your calories. Increase your protein, because these people need it, but they're so weak. They may not be able to consume large volumes of food, so we've got to pack those calories and protein in very small volumes. Think outside the box. Look at we provide these to all our customers. Look at your recipe, Reinhardt Cisco, PFG, Foods, they all have fortified recipes. This is a particular fortified recipe for peanut butter cookies. So if you see them, it's graham crackers, which are easy, adding a mixture, blend to a smooth consistency, and make a scoop of number 16 and bake it off. So those have 150 calories for 1 large cookie and 2 grams of protein. Partner that with chocolate whole milk, 180 calories, 8 grams of protein, 330 calories, and 10 grams of protein. Exceptional snack. So we can always take our recipes and fortify them. You can look and see that they have different things on these menus that help fortify them at least once a day to provide some of those delicious fortified products, such as the fortified oatmeal. We always, as clinicians, dietary managers, DONs, and RDs, need to make sure we know what the needs are by reading the chart and looking at intake. So if someone needs 2,400 calories a day, and we are only able to give them, or they are only able to consume 50%, that is only going to be anywhere to 1,000 to 1,200 calories. Clearly would not meet their needs. Extra protein calories are needed, but this person may not be able to take a lot of volume. A regular diet for most menu programs is around 2,400 calories and 85 to 100 grams of protein. Review the RD NDTR assessment, compare the intakes for meals and menus, and close the gap between needs and intakes to make a nutrition balance. Make your snacks high calorie, high protein. A quarter sandwich, which I call ladyfinger. You can get between 8 slices of a sandwich for like a pimento sandwich or a peanut butter sandwich, ice cream, yogurt, milk and sugar cookies, power pudding, which is using, you're going to use half and half and then add powdered milk to that to boost your calorie and protein count of your pudding. You also can use a brownie and chocolate milk or plain milk. So there's many different ways to use high protein, high calorie snacks. Again, many people with COVID cannot eat a lot at one time because they just frankly get winded from shortness of breath. So it may be a consideration to give them a brownie in the afternoon and maybe a ladyfinger, which will be 2 strips of a peanut butter and jelly, or either a pimento cheese sandwich and whole chocolate milk or plain milk at night, boosting those calorie intakes with less volume. So again, a lot of COVID clientele, they simply cannot consume 3 large meals a day. Our stomach can only hold 24 ounces or so a day as a normal human being. And a lot of times I am told that COVID has negative GI distress and causes the person a potential feeling of gas and nausea and fullness. So adding 5 to 6 small feedings a day, small portions at meal, and powerful nutritional snacks, for example, the peanut butter cookie and the chocolate milk, 330 calories and lots of protein to support skin healing and COVID recovery success. Make your food a fortified food program. It's certainly not going to help anybody to have extra butter and powdered milk in a soup like cream of tomato. Look at your bread program. It's great to have a soup kettle and bread program and lots of buttery sauces to go with that bread. Who wouldn't like honey and butter on a piece of cornbread and tomato, cream of tomato / basil soup? Aromatherapy can be used by therapy to have an odor-inspired cooking machine, and that fills the entire facility with smell that's very appetizing. Socialization is important at meals. So an example of how you might use a soup cart in a dining area would be to see Mrs. Jones. You take the soup cart up to the foretop. You visit with them. We have tomato soup and let's say the other cream of tomato soup, and she's frail. She weighs 90 pounds. And we also have a salad. So your CNA, if she's on the red napkin program, can say, Mrs. Jones, would you like the tomato soup today? And guess what? We've got honey cornbread, and I have butter. Would you like for me to pre-butter it for you? And we have delicious grape punch. So it ends up to be 720 calories, and if she eats 50% of that, I would be ecstatic because that's a great meal. A 100-pound female, remember, for females, you can take their weight times 10 or 12, and that's about how many calories they need a day unless they have a comorbidity that increases their calorie needs. So a lot of these frail elderly people, by fortifying their meals, you can get a lot in them with less volume. So that's really key. Aromatherapy benefits us all. Hadn't you rather walk in a nursing home instead of smelling Brussels sprouts, smell biscuits. So when we're making those products, let's keep the dining rooms open, let's keep the smell, let's think about putting an Otis Spunkmeyer machine in activities or the lobby. Let's look at doing dessert carts and with piping hot cobbler with the smell. Let's look at soup carts, and let's look at buns being hot and available with the odor coming in the dining room area. Dessert carts are great. And to keep your costs down in your dining area, you can always have a fortified cookie for those that need those extra calories. Attractive dessert carts can make your food costs go down. You can use them for leftovers. You can get this particular ice cream cookie, has 500 calories and 4 grams of protein, and it looks beautiful. You can have cobblers, you can have cake, you can have sheet cake, all relatively inexpensive products that we can doctor up and add more calories and protein and then boost the calorie intakes with very small volumes of food. As clinicians, we know that people eat with their eyes. We do. So we encourage you to work with your food service directors and your team and your nursing department to make sure our food is presented in the most attractive way possible. So which plate would you eat? Would you like to have the pureed rice, and even though it's formed, pureed fish, which is light grayish brownish, tan maybe, and then white light tan, no color variety? Or had you rather have a plate that has fried chicken strips, mashed potatoes or rice, and asparagus or green beans? Lots of color variety. Remember, we all eat with our eyes, not just our mouth. By providing low calorie and high calorie beverages, it can be a really, really positive way of getting extra calories in individuals. So it's very, very easy to get dehydrated when you're elderly. When we get elderly, our kidneys are not able to tell our brain that you need to drink. So we need to flush those fluids, push fluids. We can do that with residents that have inadequate intakes by making it taste good. High calorie, low cost beverages, fruit punches, tea with sugar, grape punch, Kool-Aid type beverages, lemonade type punches, those all in eating adequate fluid intakes can help reduce falls, infections by keeping our bodies healthy. So patients that need thickened liquids, we need to pay special attention to them and really make sure that they do get enough fluids and enough calories. 1 8-ounce glass of the lemonade has 120 calories. Again, looking at all calorie sources to keep that weight up. Here's your punch. Another product, and only costs 3 cents. A lot of bang for a very small buck. So, and I'm giving a class in the near future on this, and I hope everybody will be able to attend that. One of the biggest issues that we're getting concerns about is the lack of socialization in dining rooms. You know, we are being so careful, and we appreciate that, to avoid COVID. But one of the main concerns about getting COVID is isolation. So people that are isolated, they simply don't want to eat. Mealtime traditionally is a socialization time. So how can we make our dining programs social events? By using plexiglass so people can sit together and be safe. By giving them choices. By creating a positive music-fueled atmosphere. By making it fun. Cinco de Mayo meals. Tuesday tacos, lots of different ways to make those themed meals. Italian Day, Country Fried Chicken Day, lots and lots. Look at calendars, they have all kinds of days like Ice Cream Holiday. Garnish plates. You don't want white upon white upon white on a white plate. So if you have fried chicken, mashed potatoes, you have green beans, and you have a curl of an orange on there, that's very, very attractive. Making sure that the OT is seeing those people that need adaptive equipment, and we're providing it on the tray and we're care planning it. Making sure that someone is in the dining room, manager on duty, encouraging the staff to make sure they're doing what they do. Again, inspect, don't expect. Having conversations with those individual residents. How are you doing? What's going on? You miss your family? I understand. Let me give you an extra piece of that cobbler and let's make that better for you. Music in the dining room. An MOD means a manager on duty. I'm a big advocate for people do what you inspect, never what you expect. So here's an example of an attractive dining room. Now there in the far corner, there is a table over there with a plexiglass. Making sure all your food looks really good. And if you look, that cupcake only took some pre-made cookies, a couple of chocolate chips, and it also is a plain yellow sheet cake batter dumped into a cupcake, baked off, ice the next day, and look what you have. Same thing for this brownie. Very attractive. Save your leftovers. If you have leftover heels of bread, make your bread pudding from it. If you have extra things that are left over from bread, make bread pudding. If you have other things such as leftover pudding and leftover cake, make a parfait. So use those leftovers frequently and healthfully to make these residents excited about what they're eating. So this slide was provided to me by our staff, and I wanted to thank them for providing this information to help us make those foods that for isolation, because we have facilities that have had up to 60 people COVID positive. So what do? Well, we were using isolation and the hinged styrofoam cups and plates. So Darren DeWitt, Johnny Dean, and Eric Jones have a culinary background and also are RDs that work with nutritious lifestyles. They top their hot food with aluminum foil. They have found that increases heat retention. Casseroles, like for example, egg casserole, increases heat retention. Batch cooking, keep cold in your cold containers, keep hot in hot. Avoid soggy food by using portion cups for your sausage. Personalize that hinge with the name and a smiley face. They will appreciate that. That is a way of socializing with them even though you can't see them. Use baggie / Ziploc and put ice in it for cold items on the cart. Use garnishing more for those isolation trays. Again, they don't get to get out of their room and see people. Add pops of color. Add an orange wedge, a slice of melon, pickle wedge, pickle spear. Lots and lots of opportunities. A slice of beets, slice of spiced apple rings. Use fresh herbs. Use shredded cheese and bacon bits on potatoes and soups. Desserts. You can easily make a sheet cake for $10 to serve most of them in a nursing home. Put a Cool Whip type topping on it and put a chocolate chip or two, and you've got a great dessert or drizzle with sauce. Add sauces and condiments using squeezed bottles. So we can make some of our pureed foods and also soup foods of the day. We can save our leftover piece of chicken, piece of beef, etc. daily after the tray line. Instead of throwing out one chicken breast, we can freeze it, we can puree it, and we can add it to the soup for those COVID-19 residents' benefit. We can save leftovers from the day before to offer as alternates for our residents. Everyone likes choice, even someone that may not be eating that well. It may improve their content of their meals and their caloric intake if you give them the option to choose. Everyone wants choices in life. Create a high calorie, high value nutritionally dense snack rotation. Alter your menus to get the very, very best retention on foods for hot and cold you can to go to unit trays. Use aesthetic appeal, color, temperatures, and shapes at meals, especially isolation trays. Try to put your mind of how you would accept the tray and make sure it would be one you would want to eat from. There's a lot of negative factors with COVID, especially now. Some of the states are opening up to visits and surveys, by the way. But a lot of these patients, they don't understand COVID, and the staff don't understand it either, and it causes a great amount of anxiety. Send that referral to social services so she can work with the physician and that patient on the increased activity, staying busy, etc. At any point, if a resident cannot eat, COVID or not COVID, and is losing weight, for example, maybe their throat, they were on a ventilator and their throat is so sore that they can't swallow, you immediately need to refer that to ST, RD, etc. So get them involved. If any point a resident cannot eat, is losing weight, develops a pressure ulcer, you need to reach out to your RDN immediately, or DTR. We are there for you. We all have cell phone numbers, and we can be contacted electronically as well by email. Does the resident, as we're going through this COVID experience, have they lost weight? Can they feed themselves, or do they need help? If they do, help them. Recommend that they be seen by OT or ST to assist them in meeting their own nutritional needs. Individual plans of care should be based on the residents and what they need and what they want. We are all different. Some people with without COVID want 4 feedings a day, and that's okay. We're all different. We're not cut out of the same clothing model. So again, COVID can fatigue and weaken individuals. They may need frequent hydration and texture changes. They may get COVID on a Monday, be on a regular diet, and they're so decompensated and weak by Thursday, they need a mechanical soft. So that is a constant change, and communication is key with nursing, the RD, DTR, speech pathologists, and occupational therapists. We've got to look at what they need and close those gaps to get good nutrition to keep them healthy. We need to focus on our interventions being feasible. We need to monitor for outcomes. If you do an intervention and they're still losing weight, go back and rethink the intervention and try something different. Doing new plans of care based on new problems and revising old plans of care, if you will, based on updates and changes in acceptance of interventions and changes in goals and approaches. COVID is a team approach. Again, hand sanitation, masks, sanitizing, and disinfecting the kitchen areas are important. We are working together as a team. Food service, RD, NDTR, dietary manager, CDM, nursing, rehab, OT, PT, the physician or their delegated nurse practitioner or physician's assistant, and social services. This is truly a team disease, team problem. Remember, nutritious lifestyles is a click or a call away. We are here for you. Please reach out to Logan Stackhouse at the above email if you need anything we can do, help you with cost control, help you with survey preparation. We are here from you. If you need to get information about your CEUs, Michelle Mabry will be available to you at the email address. And my name is Janet McKee again. I thank you for your time, and I value the opportunity to work with you. Thank you.